And Dobson, any other apologies? Okay, a few items, members, under Chair's business. There's a draft of the mental capacity bill that is now being produced, and the two departments are currently seeking executive approval to introduce it to the Assembly in May. And members are aware it has been previously agreed that there will be an ad hoc committee, joint committee made up of members of Health and Justice, and it will be established to consider the results of the public consultation and also to undertake the committee stage of the bill. In order to progress this, I'm just seeking agreement to write to the Speaker to request that the Business Committee establishes the ad hoc joint committee in accordance with Standing Order 64C, with the membership drawn from the membership of the Justice and Health Committees. The Justice Committee has already sent a similar letter, so our members agreed that we do the same.
Yeah, great.
Okay, secondly, members, just given the financial restraints on the Assembly 15-16, the ad hoc committee is being staffed from within existing resources between the two committee office teams. So this means that the clerk has had a look at how some staff can be freed up from existing tasks, and I would ask members to cooperate with us in order to just create capacity, because obviously the legislation coming forward is the biggest piece of legislation that the Assembly has ever dealt with, and we've quite a heavy workload on top of that. So the outcome, members, is that there will be no more paper meeting packs produced for the Health Committee members from the week after the election. The last paper pack sent to be provided will be for the meeting of the 29th of April. Members who wish to use a paper pack, and I know members still do, should really make arrangements with their own staff to provide one. I think it will, fairness to say, free up some of the committee staff's time. The electronic packs will continue to be sent on the Friday before each meeting. I just want also to note as well that the committee office staff will be no longer managing my diary as chair. That will be done through my own office, and also the issue about accompanying me to certain meetings. So we will, and I would ask members to cooperate. We do need to free up staff's time as much as possible given the pending workload. Members okay with that? Yeah. Just also advising members that a session has been arranged to look at the draft Health and Social Care Control of Data Processing Bill with the assistance of Daniel Greenberg through Politics Plus. Daniel Greenberg had wrote the booklet for members on deconstructing legislation. The session will last just an hour. It is specifically on legislation. It will be scheduled from 2 o'clock to 3 o'clock on the 27th of May, and we would then begin our normal meeting at 3. Our members agreed? Yep. Also advising members that myself and the Deputy Chairperson met with the new Children's Commissioner on Monday to talk about some of the key issues her office will be dealing with. One of the issues discussed was the progress that's been made in relation to implementing the recommendations from the Marshall report on child sexual exploitation. I'm suggesting, members, that we write to the department to ask whether the action plan has been produced yet, and what the involvement of the Children's Commissioner and the voluntary and community sector will be in implementing the action plan, and how many times has the cross-departmental officials group met. Members in agreement with that? Item 3 then is the draft minutes of the meeting on Wednesday the 15th of April 2015. Just referring members to the draft minutes which are on page 5. Are members content with the minutes?
Right.
Item 4 is the Food Hygiene Rating Bill. It's a formal clause-by-clause scrutiny. Again, advising members that the committee has carried out its informal clause-by-clause on the majority of the clauses of the bill on the 18th of March. The committee had indicated that we were generally content with the approach that the Food Standards Agency were taking to amending clauses in response to issues raised by the committee, and that no further information or discussion was required except in relation to clause 7 and the issue of displaying rating online. Again, just to inform members that the committee had obviously discussed this issue last week, and also discussed the proposed amendment that was produced from the Food Standards Agency. We were generally content with the amendment. However, we did seek assurance that the powers will be exercised in the first set of regulations drafted after the Act comes into operation. We asked the FSA to seek a written assurance from the Minister on that point. We now have that assurance at page 3 of your tabled pack. So are members content? Just give members a minute to reflect on that. Content with the assurance from the Minister, and that we require no further discussion of the issue before we would move into clause by clause.
Right.
Grant. Okay, thank you, members. Just reminding you then that this is the formal clause by clause consideration, so it is a vital and essential part of the committee's duties and needed for the preparation of the committee report. It is, members, the final opportunity for the committee to propose any amendments. So I'm advising you that I'll be formally putting the question on each clause, and the committee is required to vote that it is content with the clause as drafted, or content with the clause drafted subject to departmental amendments, or that it is not content and wishes to amend, or that it is content and wishes to oppose the clause. So I'm referring members to the black and red copy of the bill which is in front of you, so that we can go through each of the clauses. So clause 1, members, deals with the production of food hygiene ratings. The department is not proposing any amendments. Just reminding members that the committee had indicated that we were generally content with the clause. If so, then I would put the question, is the committee content with clause 1 as drafted?
Right.
Agreed. Clause 2 sets out the arrangements for notification and publication of the rating. The department is proposing a number of amendments which are to allow councils to provide some information at an earlier date than the notification of a rating, to introduce a timescale of 34 days within which councils must inform the FSA of a rating, to introduce a timescale of 7 days after the end of the appeal period in which the FSA must publish the rating online, to define the end of the appeal period, and to allow for the potential of there being different types of stickers, such as those with council branding, and to specify who will pay for the different types of stickers. Again, we had considered this and were generally content with the clause and the proposed amendments. Therefore, is the committee content with clause 2, subject to the proposed departmental amendments?
Right. Chair, is those the writing in red? That's the amendments, I presume. Yes. Yes.
It is, yeah.
That's okay.
Members agreed with clause 2 then? Yes.
Right.
Clause 3 deals with appeal. The department is proposing amendments to require a council to inform the FSA of the outcome of an appeal, or if the appeal has been abandoned. If the rating has changed as a result of the appeal, the FSA must publish the new rating within 7 days online. Again, we had considered this and were generally content with the clause and the proposed amendments. Therefore, is the committee content with clause 3, subject to the proposed departmental amendments?
Right.
Clause 4 deals with re-ratings. The department is proposing a number of amendments to clause 4, which will require a council to notify the FSA of the outcome of a re-rating within 34 days, to require the FSA to publish the new rating online within 7 days of the end of the appeal period, and to allow the department, through subordinate legislation, to limit the number of occasions on which a business can request a re-rating. Again, we had considered this and were generally content with the clause and the proposed amendments. Therefore, is the committee content with clause 4, subject to the proposed departmental amendments?
Right.
Clause 5 deals with right of reply. The department again is proposing a number of amendments to specify a time period of 7 days in which the FSA must publish a right of reply online, and to link the publication of the right of reply to the publication of the rating to which it refers. Again, we had considered and were generally content with the clause and the proposed amendments. So is the committee content with clause 5, subject to the proposed departmental amendments?
Agreed.
Clause 6 deals with the validity of a rating. Again, the department is proposing a technical amendment to remove clause 6(4), given that the end of the appeal period is now covered in the amendment to clause 2. Again, we had considered and we were generally content with the clause and the proposed amendment. Therefore, is the committee content with clause 6, subject to the proposed departmental amendment?
Agreed.
Clause 7 deals with the duty to display a rating. The department is proposing an amendment to provide for a regulation making power to require businesses supplying food by means of an online facility to ensure that the establishment's food hygiene rating is provided online. The manner of display would be specified in the regulations and would include providing a link to the Food Standards Agency website. We have now received written assurance from the Minister that the powers will be exercised in the first set of regulations drafted after the Act comes into operation. Again, we had considered and were generally content with the clause and proposed amendment. So, are the committee content with clause 7, subject to the proposed departmental amendment?
Yep.
Clause 8 deals with the duty to provide information about a rating. The department is not proposing any amendments. We had considered and were generally content. Therefore, is the committee content with clause 8 as drafted?
Okay.
And clause 9 deals with enforcement and powers of entry. The department again is not proposing any amendments. We had considered and were generally content with the clause. Therefore, is the committee content with clause 9 as drafted?
Agreed.
Great. And clause 10 deals with offences. The department is proposing an amendment which is a consequence of the amendment to clause 7 and will mean that a failure to comply with the duty under clause 7 would be an offence. Reminded members that the committee had indicated that we were generally content with the clause and the proposed amendment. Therefore, is the committee content with clause 10, subject to the proposed departmental amendment?
Agreed.
Clause 11 deals with fixed penalties, and the department is not proposing any amendments. Reminding members that the committee indicated that we were generally content with the clause. Therefore, is the committee content with clause 11 as drafted?
Agreed.
Clause 12 deals with the provision of information for new businesses. The department is proposing an amendment to allow councils the flexibility to provide information to businesses at different stages of the registration process. Reminding members that the committee indicated we were generally content with the clause and the proposed amendment. Therefore, is the committee content with clause 12, subject to the proposed departmental amendment?
Agreed.
And clause 13 deals with mobile establishments. The department is not proposing any amendments. Again, reminded members we did consider and were generally content. Therefore, is the committee content with clause 13 as drafted?
Yep.
And clause 14 deals with the review of the Act. The FSA is proposing a number of amendments to clause 14 to take on board the committee's concerns that the clause as drafted is too wide-ranging. The FSA are going to remove clause 14 part 8 and include an amendment to require the department to publish its response to the FSA report on the review of the Act. The FSA is also proposing an amendment to require them to promote the scheme. Again, reminding members that we did consider this and were generally content with the clause and the proposed amendments. Therefore, is the committee content with clause 14, subject to the proposed departmental amendments?
Yep. Agreed.
Clause 15 deals with guidance. The department is not proposing any amendments. Just reminding members that the committee indicated that it was generally content with the clause. So is the committee content with clause 15 as drafted?
Agreed.
There's a new clause, adjustment of time periods, which will allow the department to amend the time period specified in the Act by substituting a different time period. The new clause will also allow councils and the FSA itself flexibility around meeting various timescales in the Act because of, for example, Christmas closure of council or FSA premises and because of exceptional circumstances. We had discussed and had indicated that we were generally content with the new clause. So is the committee content with the new clause, adjustment of time periods, as drafted?
Right.
And clause 16 deals with interpretation. The department has proposed an amendment in relation to the definition of the end of the appeal period. Again, we had considered and were generally content. Is the committee content with clause 16, subject to the proposed departmental amendment?
Right.
And item 17, with transitional provision, the department is not proposing any amendments, and we had indicated that we were generally content with the clause. So is the committee content with clause 17 as drafted?
Right.
Clause 18 deals with regulations and orders. The FSA is proposing amendments to take account of the amendments made to clauses 7 and 14 and to specify how subordinate legislation will operate in relation to the new clause on adjustment of time periods. Again, members, we had considered and were generally content with the clause and the proposed amendments. Therefore, is the committee content with clause 18, subject to the proposed departmental amendments?
Right.
And clause 19 deals with Crown application. The department is not proposing any amendments, and we had indicated that we were generally content with the clause. Is the committee content with clause 19 as drafted?
Right.
And clause 20 deals with the short title and commencement. The department again is not proposing any amendments. Again, reminding members we had discussed and were generally content with the clause. So is the committee content with clause 20 as drafted?
Right.
Schedule deals with fixed penalties. The department is not proposing any amendments. Again, reminding members that the committee indicated it was generally content with the clause. So therefore, is the committee content with the schedule as drafted?
Right.
Long title, is the committee content with the long title of the bill as drafted?
Right.
Okay, members, thank you for your cooperation on that. Next item, item 5, is the review of workforce planning in the context of transforming your care. I just want to refer members to page 14 of the meeting folder and page 4 of your tabled papers, advising members that representatives from the Royal College of Nursing and the Royal College of Midwives are here today to brief members on workforce planning in the context of transforming your care.
Afternoon.
Just give you a chance to get settled. Folks, you're very welcome. We have Garrett Martin, Deputy Director, Royal College of Nursing; Rita Devlin, Head of Professional Development, Royal College of Nursing; Maureen Doolan, Vice Chair of the RCN Board; and Breda Hughes, Director of the Royal College of Midwives. So I'm going to invite yourselves to make the presentation from both organisations, and then we'll open it up to members' questions or comments or observations. Garrett, is it yourself?
Thank you,
Okay.
Madam Chair. The RCN thanks the committee for the invitation to submit evidence in relation to workforce planning in the context of transforming our care. Members of the committee have received our briefing paper, hopefully, which will hopefully have been helpful in preparing the ground for today's session and informing the work of the committee on this issue. In the briefing paper, we've endeavoured to address the specific issues that were raised with the RCN in our invitation to attend today. We would also introduce some additional themes that we feel is important for the committee to consider. The briefing paper provides some background information in relation to the workforce planning process for nursing and midwifery in Northern Ireland. It explains how, in July 2013, the RCN presented to former Health Minister Edwin Poots a detailed analysis of the nursing workforce in Northern Ireland, highlighting the challenges that needed to be addressed in order to help build a nursing workforce that would be fit for purpose in addressing the significant healthcare challenges confronting Northern Ireland in the years ahead. We note at paragraph 12 of the committee briefing paper our specific concerns about a recent document from the Department entitled A Workforce Plan for Nursing and Midwifery in Northern Ireland 2015 to 2025. The RCN is particularly concerned about the growing number of nurses who are leaving Northern Ireland to work elsewhere, the increasing staff vacancy levels in nursing reported in the DHSSPS vacancy survey, the growing number of entries on HSC Trust risk registers detailing the risks associated with nurse staffing shortages, the increasing use of bank and agency staff and associated escalating agency costs, and the fact that there are insufficient financial resources to meet demand for the specialist and advanced nursing roles required to support the medical workforce, resulting in the further depletion of an already overstretched nursing workforce. The paper highlights the impact of inadequate or non-existent workforce planning on the nursing home sector and GP services. We live in an integrated health and social care system where the statutory sector coexists with the independent and nursing home sector. GP practices, private clinics and voluntary organisations in terms of providing health and social care services for the people of Northern Ireland. These areas of practice do not exist in parallel universes. They are simply part of the same system. Workforce planning for nursing must address in particular the needs of the nursing home sector and GP practices, as well as those of our hospitals, health centres and community services. We note that the committee recently received oral evidence from the Regional Workforce Planning Group in relation to transforming your care. The committee has specifically asked the RCN to confirm whether or not it is a representation on the RWPG, and the answer is to this question, and we explain in our briefing paper that we do not. The RCN is surprised and disappointed that a group of this nature, which specifically purports to include membership from across the wider HSC, could exclude the organisation representing the largest professional group within the HSC. The ultimate benchmark for the success of TYC is, or should be, its impact upon emergency department admissions. However, between December 13 and December 14, the total number of attendances at the major acute hospital emergency departments in Northern Ireland actually increased by 6%. Across all emergency departments, the increase was 3%. If TYC was designed as a means to keep people out of hospital and ensure they are able to access health services in their own homes and communities, then by this criterion singularly failed. The community nursing workforce in Northern Ireland faces many significant challenges. These include high workloads and demands on the service, excessive burden of paperwork, poor or non-existent technology, and a fear of letting patients down due to cuts in service and workforce. The demands on community nursing services have also affected the work-life balance of nurses, with many nurses working longer, unpaid hours, because this is the only way to make sure they receive the care to which they are entitled. A summary analysis of the community nursing workforce is presented in the briefing paper provided. This illustrates the numerical decline in the community nursing workforce over the last 4 years, at precisely the time when the workforce should have developed in order to deliver TYC. Secondly, the figures demonstrate the ageing demographic profile of the community nursing workforce, particularly in relation to school nursing and treatment room practice nursing. There is a further point to be made with specific reference to the district nursing workforce. As Table 2 on pages 12 and 13 demonstrate, many of the nurses categorised as district nurses by the DHSSPS are not employed as district nurses at all, but as registered nurses deployed to work in the community. District nurses are nurses who have undertaken a specialist programme subsequent to their initial registration to equip them with the high levels of skills and expertise that are needed to lead and deliver the provision of specialist care to people with complex conditions. In simple terms, 2 out of every 3 nurses whom the department categorises as district nurses are actually not district nurses at all. The paper also stresses that we need to make sure in our integrated health and social care system that we are not trying to deliver nursing care within a domiciliary care model. The RCN is concerned about a current consultation on a proposed outline for domiciliary care services. This includes, within the definition of domiciliary care services, programmes of care for older people, physical and sensory disability, mental health and learning disability. It goes on to claim that domiciliary care includes meeting, quote, a service user's health needs, for example, managing medication. This is unacceptable and potentially dangerous in the view of the RCN. When it comes to meeting the health needs of patients and clients, they require skilled professional nursing care, prescribed by, directed by, supervised and delivered by registered nurses who have been trained to provide that care and who is accountable for the quality of the care provided and the experience of the patient or client. The committee has sought views from the RCN on the number of registered nurses required to implement TYC. As the briefing paper points out, commissioning involves assessing health and social care needs and then planning and designing services to meet those needs. Workforce planning is or should be an integral part of this process. It is equally a commissioning responsibility to seek assurances about staffing in the context of patient safety, quality and experience within the services commissioned. The RCN has been involved in a regional initiative to establish a framework for safe or normative nurse staffing ranges to support person-centred care in Northern Ireland. This work is currently being undertaken in phases. Phase 1 is defined safe nurse staffing ranges for acute medical and surgical settings, and the previous Minister announced the establishment of the framework for these areas of practice in 2014. Phase 2 is intended to cover emergency departments and Phase 3 community settings. However, the Northern Ireland budget for 15-16 paper states that no funding is available to support work on subsequent phases of normative staffing. The RCN believes that this is unacceptable. The development of safe nurse staffing levels across the HSC is not an optional extra to be pursued as and when resources and other priorities permit. It is a matter of fundamental public safety that must be implemented fully and as a matter of urgency. The RCN believed, therefore, that the answer to the committee's question as to how many nurses are required to implement TYC lies in developing robust commissioning and workforce planning processes that supported and underpinned by the implementation of safe staffing levels across all healthcare settings, including community health care settings. At the end of the briefing paper, we draw to the committee's attention the statement made in the executive summary of Mid Staffordshire NHS Foundation Trust Public Inquiry, with which I am sure you are familiar with. In particular, it states that the report has identified numerous warning signs which cumulatively, or in some cases singly, could and should have alerted the system to the problems developing. I'll not read those out as they are in your briefing paper. The RCN believes that these warning signs are present in Northern Ireland Health and Social Care Service today and that they can no longer be ignored. Last year, the RCN told the committee that TYC is a vision without action. We now need to reassess that conclusion. The Northern Ireland Executive Budget paper for 15-16 states that, quote, the Department's budget does not allow for the funding of new service developments in 15-16 across a number of areas, including transforming your care transitional funding. Knowing that alternatives to acute hospital admission are being closed, with more and more patients being funnelled into our emergency departments because they are the only viable points of access to the health system, the RCN believes that we are entitled to ask if TYC remains in any meaningful respect a viable strategy. We note that earlier today the Permanent Secretary of the Department of Health was scheduled to deliver a presentation at the annual conference of Northern Ireland Confederation for Health and Social Care, or NICON, and it was entitled Beyond Transforming Your Care. If TYC is not now the blueprint for the modernisation of our health and social care service, we ask the question, then what is? Where is the new strategic direction or vision? Or are we living in a system where the only mantra is that there is no money, so we will all have to muddle through as best we can? This is not leadership. It is a dereliction of duty. I hope that this presentation in association with a briefing paper has been helpful to the committee. Thank you for inviting the RCN to your meeting today, and I hope that our evidence has been helpful.
Thank you, Karen. Breda?
Thanks very much for the invitation to come and meet with the committee, and apologies for the very late tabling of what I'm about to say. We've been otherwise engaged over the last few days. Sorry. The issues in midwifery in many ways are very different from those in nursing. For example, there's no private sector for midwifery in Northern Ireland, and nor are there any agency midwives in Northern Ireland, although we do have across the sector quite a high reliance on the use of bank midwives. So I've looked at the terms of reference for the committee's ongoing piece of work, and in particular the challenges that Transforming Your Care identified for maternity services going into the future, and these were about giving a realistic choice of birth location to women, the need for more continuity of care throughout pregnancy, the need to reduce unnecessary interventions, dealing with public health issues that face women of childbearing age to reduce ill health and disability of both mother and child, and support the expectant mother in her antenatal care and connecting that support to the early years of parenthood. Transforming Your Care went on to say, therefore, that it expects change to follow the pattern set out in the forthcoming maternity strategy, from preconception through pregnancy, birth and the postnatal period. In addition, it recommends a specific regional plan for supporting the small number of mothers with serious psychiatric conditions. At the time the Transforming Your Care was written, the Department of Health, Social Services and Public Safety was working with the Royal Colleges, with service providers, with commissioners and indeed with women themselves to develop the strategy for maternity care, which I think Mr Jimsey was Minister when it was published, and it clearly accepted the recommendations outlined in Transforming Your Care and has, for midwives, clearly identified the vision and the future direction of maternity services in Northern Ireland. It addresses women's choice, accessibility of services and who's best placed to be the lead maternity professional. I think for us it's a fairly unique document in that it's a maternity services strategy. It cuts right across all of the professional groupings. It applies equally to our medical colleagues, to general practitioners, to midwives, to nurses who work in places like neonatal intensive care units. It is a service strategy and not a uni-professional strategy. And it is supported by, and in fact it is driven forward by, our colleagues in the Public Health Agency, that there's a very robust maternity strategy implementation group which puts in place each year annual targets to be met by the end of the year in terms of moving the strategy forward. So it isn't a strategy that sits on a shelf somewhere. It is very much a living and evolving document, and it spans both the acute and the primary care sectors. Midwifery care, I suppose, or maternity care, is premised on that every woman needs a midwife, and some will need a doctor as well, and in fact some will need more than one doctor. They may need a very highly skilled team of doctors to provide them with that wraparound care. So within Northern Ireland, the service developments within maternity care are in line with maternity strategy. There has been this robust implementation of the strategy since 2013, with women now having a wider choice of birth location, with more continuity of care throughout their pregnancy, unnecessary interventions, including non-medically indicated caesarean sections, which was an issue that was addressed by the Northern Ireland Audit Office, I think probably at the request of this committee, are being reduced, and midwives are at the forefront in discussing public health issues, including drug and alcohol abuse, smoking, nutrition and exercise with pregnant women, who actually are very well disposed to receive public health messages during their pregnancy, both for themselves, their unborn baby and other members of their family. The only recommendation from Transforming Your Care that's still to be implemented fully is the development of a specific regional plan for supporting women with serious psychiatric conditions, and that work is in fact ongoing. There is a perinatal mental health working group in Northern Ireland which has so far developed very robust training to identify women at risk. It has put in place an algorithm or a flowchart for midwives to follow once they have identified a woman at risk with perinatal mental health problems. Our difficulty is that there isn't a dedicated resource for those women once they have been identified. We still do not have a single mother and baby bed where women who are seriously unwell can be admitted with their babies. So any woman with a mental health problem in Northern Ireland will be separated from her baby if she requires admission to a psychiatric unit. But we're campaigning on that one, and we will keep going, and I'm quite sure we will get it eventually. There is an evolving role, I think, for midwives in terms of decreasing social complexity and enhancing parenting skills. It's a massive transition to make. Anybody who is a parent will know, from having a bump one day to a baby, a real life human being the next day. And we're beginning to see midwives moving out to work outside of the healthcare system in Sure Start schemes, in the early intervention transformation programme that the Public Health Agency are just about to start, in the family nurse practitioner scheme. We're seeing midwives reaching out to those who are most vulnerable in the community and working with them to help them to make that transition from pregnancy to parenthood. So whilst there's been an increase right across Northern Ireland in the number of women choosing to have midwifery-led care throughout their pregnancy, There has also been an increase at the other end of the spectrum in the number of women with complex needs who are required to have their care provided by an extensive team of healthcare professions. And this is something to do with women delaying having their first baby until they're older, or women presenting for pregnancy with other ongoing diseases, particularly things like diabetes and epilepsy, renal disease, cardiac disease, respiratory disease. The midwifery workforce in Northern Ireland is predominantly female, with only 2 male midwives out of the 1,300 midwives that we have. It is an ageing workforce. Almost 60% are aged over 45, and indeed 22% of them are aged 55 and over. It is a part-time workforce, with almost 70% of midwives working part-time, and at any given time up to 5% of the workforce may be on maternity leave. So that means at any given time 65 midwives are off on maternity leave, in addition to any midwives who may be off on sick leave. Midwives work flexibly across hospital and community boundaries. This is incorporated into their pre-registration training, and it carries through into clinical practice. In order to keep them fit for practice at any point in their career, ongoing professional development is crucial as the service develops to meet women's needs and wishes. The ongoing professional development is provided, some of it in-house, some of it by the Clinical Education Centre, and some of it by our universities. But I would point out it's all unfunded, and very many midwives undertake their own CPD in their own time at their own expense. The midwifery workforce is reviewed annually in conjunction with the Department of Health. It's a group that's led by the Chief Nursing Officer. We work with service commissioners and providers, the higher educational institutes and the professional organisations, which include both the RCM and the RCN. Like Garrett, I would echo our concern. There is no midwife on the regional workforce planning group. We were completely unaware, for example, of the Skills for Health Workforce Planning Diagnostic Report that was provided to the Department in November 2013. Thank you, Sue, for giving me a copy of that. It highlighted several issues, I suppose, which might be worth, in terms of workforce planning, the committee taking some cognizance of. This report from 2013 highlighted that workforce planning by those who work in the service is seen as being reactive, it's seen as being short-term, it's seen as being focused on efficiencies and savings and not on future service development. It asks, how do you translate a service change into a workforce change? And it asks, who really owns workforce planning, and is it HR or should it be the people working in the service? So I think by using the maternity service strategy as our framework for the development of midwifery workforce planning, we're taking service developments, we're looking at the midwives that we have currently in place, we're looking at how the service is evolving and where those midwives need to be and what it is that they need to be doing, and their skills are being kept updated constantly and reviewed throughout their career. There are midwives in for places like Lagan Valley currently who worked in a hospital environment for 30 years, and when it became a midwife-led unit, they're working in the community, they're working in the hospital, they're doing home births, they transfer and rotate up and down to the Ulster Hospital to keep their critical skills updated. So they're working in very many different ways, I think more ways than anybody ever really envisaged previously. However, it is still an enormously popular career. The applications to Queen's University this year have been 534 applying for the 3-year midwifery course and 75 applying for the shortened 18-month course, which is open to those who already have a nursing qualification. So still a very attractive career option. The introduction of maternity support workers to the maternity workforce has provided support to midwives caring for women and has provided added value to the care that women receive. We have, working with the BSO, developed a single training scheme here in Northern Ireland that is adapted by each trust individually to meet their particular service need. So in some places you will have maternity support workers working in theatres, in some places you'll have them working in the community, in some places you'll have them supporting breastfeeding women. So it's about tailoring their usage to meet local service need. I suppose the major threat to the midwifery workforce is that an ageing workforce with the ability to retire at 55 as many of them do have, may, in today's difficult environment, choose to exercise that right. That will leave us, if they all go in the next couple of years, with an immediate 22% depletion of the workforce. So it's in everybody's interest to keep our midwives at work and happy at work and motivated to be at work. So if there's anything that we can add to that by way of answering your question, I'm happy to do so.
Thank you. Thank you all for that. I think very clear briefing from both organisations. I suppose just by way of opening up the conversation, just to extend the committee's thanks for being here, but also to say that the work that both your organisations and many staff conduct and carry out on a daily basis is vital for the delivery of our health service and for our wider society. And I hope that you do genuinely hear that message from us. And I picked up on a few points that Garrett had said initially. The reason that we're doing this piece of work is that we view workforce planning as integral. And, you know, personally speaking, to promote a strategy and then only start to engage in workforce planning a number of years down the line is certainly not foolproof. It would seem that the first port of call should have been looking at your workforce needs and planning accordingly. And I think that that's the message coming from this committee, and that's why we've undertaken this piece of work. And, you know, we are uncovering a lot of the same patterns, it's suffice to say. But, you know, when you start to look at something in the region of 29 reviews and the aspects of the workforce, with a number of reports, we heard from the GPs last week, but a number of reports that haven't been actioned. There's a real challenge in the system if we're serious about the shift left. And that probably leads me on to a very direct question to both the colleges. I know that particularly the College of Nursing, when you were here previously, had talked about transforming your care as a vision without action. You know, and I note now that you say that you're quite entitled to ask the question, does it remain a viable strategy? My question would be, is transforming your care dead, in your view?
Well, I suppose my response to that, or the college's response, is what options have we? And community care, absolutely, and TYC principles within it. I think there's very few things sometimes in healthcare that gets the consensus that TYC got going back 3 years. I think you had very few people who were saying this is a bad thing. It absolutely is the right thing to do. The problem that we have, and the problem that we see day in, day out, and patients see day in, day out, is that it isn't being delivered. And when you look at some of the figures that we have provided, whether it be around not just emergency department waits, but another statistic that I heard recently, which I think is quite damning in relation to TYC, is the increase in numbers of delayed complex discharges. And that in itself would indicate that the process for getting patients out of the acute hospital in a timely and safe fashion, that the community services are in place to facilitate that. There has been a 30% increase. This was presented at an unscheduled care workshop a number of weeks ago. A 30% increase in the number of delays, complex discharges. These are patients who, older people, vulnerable people who need packages of care. And that is an indicator that services in the community are not there. And you see the figures in front of you in relation to district nursing, and I think most patients and most members of the public understand that the district nurse is the cornerstone in terms of coordinating the care for patients in the community. They're the people who liaise with the different services, who make sense of services for patients in the community. And that 6% reduction over the last 4 years, which at a time when that should have been increasing, just shows that TYC cannot be delivered if these figures do not change and if the workforce does not change.
Okay. Can it be fixed?
Well, I wouldn't be as pessimistic to say that it can't be fixed, but we're starting way beyond a period that we should have started. This should have started not just 3 years ago when TYC was published. It should have actually started long before that. Community care and care in the community is not a new concept. TYC wasn't the first strategy document to identify community care as the right way to go. I think it does require funding being put in the right place. It does require commissioning to work better in terms of transferring that resource from the acute sector to community. But I think it certainly needs a major overhaul in terms of how things are being done.
And from your point of view,
I think we were starting from a different place because there had already been a move, a very strong move, driven by service users, by the women themselves, to demedicalise maternity care where this was possible. So by the time Transforming Your Care was being developed, in tandem with that, the maternity strategy was also being developed, and it looked at how do you keep care locally accessible for women. Well, you have to make a difference then between those women who are low risk and for whom this is an option, and those women who have high risk pregnancies for whom they need complex teams caring for them, but you don't treat every single woman as a medical disaster just waiting to happen. So that groundswell was already being driven forward by women, by the maternity services liaison committees attached to each of the trusts. So I suppose we started much further back in terms of maternity services. We did already have that move to decentralise, to keep things locally accessible, to centralise the services that needed to be centralised, and to make everything else as locally accessible as we could. For example, plans were well underway by the time TYC was published to open a midwifery-led unit in Downpatrick, and then closely followed by one in Lagan Valley, now one in the Mater. So the service has evolved and continues to evolve, but that process had started before TYC was sort of issued as a strategy document. In fact, we did often wonder, did they copy our maternity strategy when they were writing TYC? Because it embodies very many of the same
Never would do a thing
principles. So the issues were very different, I suppose, and we did start from a different place. And but it's also a case of when you're only looking at one discrete service, like maternity services, you can make those changes more easily. There are less groups of people involved. You generally don't have very ill people, and I think that was easier for us to accomplish. I think it's much more difficult, as Gareth has highlighted, where you have any sort of a dissonance between the acute sector and the community sector, and people get stuck in the system. Women now flow in and out of maternity hospitals. Midwives flow in and out of maternity hospitals. A woman goes in if she's completely low risk, if she delivers in a midwife-led unit, whether it's a freestanding one or an alongside one in one of the bigger units, she's in, she has her baby, she goes home in 6 to 12 hours. There's a seamless pick-up then by the community midwifery service. In fact, the midwife that came in and delivered her might also be the midwife that sees her at home. So our issues were different, and we were in a different place at the point where this process was starting. But we share the concerns about the funding, particularly because although the service has changed, the funding structure remains the same, and it's calculated on an old formula that just takes the number of births in each trust and then gives them the funding according to the number of births. It doesn't actually look at the complexity of need of some women and their babies, and some will have very complex needs and will be a very expensive birth, and other women will have never see a doctor at any point during their pregnancy or birth or afterwards. So they don't have complex needs and they don't cost a lot of money. But because it's just done on this, look at the total number of births and then allocate the funding, that's not helpful, because it means we don't have the flexibility to redirect some of those resources into the community. For example, why does every woman have to go queue up in a hospital for 2 or 3 hours to have a scan to be told you are definitely pregnant? We would love that to be done in the community by community midwives, but they have to buy handheld scanners and they're expensive. So it's about redirecting some of the resources that are currently concentrated in the acute sector to get them out into the community sector, to allow that element of care to be transferred also out into the community and keep services locally accessible for women and their families.
Yeah, Rita,
Oh, no, sorry, I was just going to say, in context of TYC and workforce planning, it has two strands, one being numbers and the other being the knowledge and skills and expertise. And if you look, Northern Ireland are the only one of the 4 countries that aren't going to increase student nurse levels this year. And on the other hand, the education budget for post-registration nursing education and development to help nurses keep up the skill, it's also been reduced. So we've reduction in numbers potentially coming in, and then we've reduction in the budget to keep them trained and developed to bring forward new ways of working and transformation.
So, in terms of what you have, both organisations, both colleges have outlined on the pressure that's within the system, and we've seen that in the last 24 hours in your decision in terms of industrial action. Is nursing safe? Is midwifery safe?
Should we ask our patients safe?
I think as long as organisations like ourselves have access to those who are making the decisions, I personally would be confident that we can get the ear of the relevant person and raise concerns directly. I think we're in a better position here in Northern Ireland than our colleagues in England in particular, because there are so many hoops to jump through over there if you wish to raise a concern. I think we're probably in a better position, but having raised the concerns, it then depends on what action is taken as a consequence of those concerns being made known.
And from nursing point of view?
Yeah, certainly there are. There's real evidence that there are real concerns that patient safety is at risk. We hear that very often. Whether it's to do with staffing numbers and levels of nurses on wards, or even in community settings, because we do see in reports, particularly in the community, more and more where caseloads are increasing significantly. The acuity, i.e. the dependency of the patient, the needs of the patient has increased significantly in the community, and they're rushing in and out of patients' houses to make sure that they can get round to see all of their patients, and they are identifying that as a major risk. And also, as Rita has pointed out, the skills, it's not just about numbers. It is about the skills and the skill mix of the staff who are caring for patients. And we see in areas like emergency departments where very experienced staff have left because they can't take it anymore. They have had enough. They are burnt out. We've heard of one recent department where 12 experienced staff left within a short space of time. That's a massive chunk of experienced and skilled staff to leave departments. That you may, if you're lucky, be able to backfill those with new staff, but new staff take time to orientate and induct and develop to a level where they are competent. So absolutely there are real safety concerns there. And that's something that nurses struggle with on a day-to-day basis. But they do their best. They go over the call of duty, as you know, to try and make sure that patients are as safe as they possibly can be.
And we share the concerns about skill mix, with 22% of midwives aged over 55 and feeling the pressure sometimes. It's like a domino effect. If you have a department and one person retires, they come in and they tell everybody how wonderful retirement is. Within the next 6 months, half the department's gone. And they can, and they do. And that is our nightmare, that we will be left trying to fill that gap. And even if we can manage to recruit the midwives in and train them, they're coming out at the end of their 3 years very inexperienced. It takes a number of years to reach a high level of competency, whether it's nursing or midwifery, in any particular arena. So we do have a huge concern about that as well.
Okay, I mean, and that's obviously of concern to us all, that we would hear, on people who are delivering such a vital life and death service, if you like, for both your organisations, that patient safety may be at risk. It's of concern for sure. Can I just ask, and I know, Maureen, that you wanted to come on this, but what's the urgent action that is required here? I listened carefully to yourself, Brita, and others in the last number of weeks and months around, the hard decisions, the genuine dialogue, not just based on budgets and money in the system. So if somebody was to say to you, A, B and C needs to happen urgently, what would that be?
I think it's very difficult to have an urgent answer, because it takes time to train people. One of the first things that needs to be done is the number of pre-registration places needs to be increased. Absolutely. I think if there's one thing in particular, we certainly need to see a significant investment in post-registration education support for nursing staff to undertake these programmes, whether they be specialist practice or other advanced practice programmes, to allow for some of these changes to take place. We absolutely need the normative staffing or safe staffing levels implemented ASAP. We need phase 2 and phase 3 of that to be carried out and to be supported, not just to be not necessarily a paper exercise, but we need the funding to follow. If the professions and nursing profession is saying very clearly that there's a certain level of staffing that is required to provide safe and effective care for patients, then it is an obligation that needs to be funded and resourced. So they, I suppose, won't happen overnight. We appreciate that. But what we would absolutely want to see is a commitment for that to happen.
Okay. And sorry, Maureen, I want to bring, because you had indicated you wanted to respond there.
Thank you, Madam Chair. Just to concur with what Garrett was saying, as a nurse myself, working on the front line, I find it very difficult, and members would also say how difficult it is to work on the levels of staffing that we have at the moment. Not just the level of staffing, but the experience of the staff coming to help in the wards that are maybe agency or bank staff that are not used to the environment that they're going into. For instance, acute services where we're working in surgical wards, and inexperienced staff are coming in. It adds to the workload, it doesn't assist the workload. A lot of experienced and valued members of staff are leaving, as Garrett says, not just for early retirement or that sort of thing, but actually leaving to go to work in private agencies that pay better. There's less incentive for staff to stay where they are, including pre-reg staff, when they know that if they go to England or anywhere else, America, Canada, that they will have incentives to work.
Yeah, and I mean, it's useful because that was one of the issues that came out when we were looking at unscheduled care. That, you know, people often reflect on recruit, but the debate is actually about the types of recruitment and the types of staff that are required. But just, Garrett, it has come back to your point, because you touched on it there in relation to the pre-registration places and programmes, but I know that your briefing paper had talked about the trusts are now commissioning sufficient places and programmes, such as district nursing and health visiting. Why is that happening, or why is that the case?
Well, health visiting there has been a specific issue with, and there was an increase in the number of commissioned health visiting places because of the risk associated with the caseloads in that, and that is to a certain degree being addressed at present. I think it's to do with funding. I think it's to do with pressure. I think trusts, because the department don't provide backfill for a number of these programmes, they simply say, you know, the individual has to do it in their own time, which, you know, for a professional to try and develop their career and their expertise and skills and working in a very stressful clinical environment as well, that's very, very challenging. So quite often, and more often than not, it is absolutely to do with resources and no backfill to provide I suppose, the cover whenever those people are out doing those programmes.
Okay, and one of the other things, just because I know there's a number of members that want to come in on this, but again, your paper, Garrett, talked about staffing shortages within the independent nursing home sector, and
absolutely,
that's a serious risk, I would suggest, to
absolutely
viability of those nursing homes.
Almost a third of our members actually work in the independent sector. These are, as you all know, nursing homes. There are 10,000 nursing home beds. These are our older population, and we believe the service, i.e. the Department of Health and the HSC as a whole, has a responsibility to ensure that there's a workforce, a nursing workforce that's able to staff those independent nursing homes. And what we're seeing is that they have significant levels of vacancies. They're finding it very, very difficult to recruit. One large independent provider, and I've provided the figures in the paper, of 150 registered nurse vacancies. They recruit from the EU. There is, as you know, probably a ban on recruitment outside of the EU, which is a challenge in itself. I think there may be some things that could be looked at in relation to that might help, but these nurses who are recruited from within the EU they spend a period of time within the private sector, independent nursing home sector, and then after a period of time, because we're in a cycle where there is a lack of supply for the demand, trusts are then being able to employ these nurses from other parts of Europe, because the independent home sector can't compete with terms and conditions and the pay. And trusts are now recruiting those, because trusts are now reporting large vacancy numbers as well within nursing. So it's almost that perfect storm in terms of nursing workforce. We did highlight the risks a couple of years ago. We had the demographic profile of nursing, and within certain areas it was much, and district nursing being one of them. We had changes to pension arrangements. We had the reduction in pre-registration nursing programmes. So that was inevitably going to leave a deficit in relation to supply of the nursing workforce going forward, and that's exactly what has happened. And unfortunately, the warning signs were not listened to, and that's why we're in the situation and we're playing catch up. If we don't, from now, start picking this up, 2 or 3 years from now, we'll be sitting at this very table, I'm sure, in a worse situation than we are at present.
Okay, that's...
I suppose midwifery again is slightly different in that we have a very robust workforce planning tool. It's called Birthrate Plus, which helps us to sit down and look at the way a service is configured and then work out. There's a little bit of a guesstimate in there, but pretty much it's based on a huge amount of data, and we can work out how many midwives are needed at any particular time in any particular place to staff the service safely. That has been backed up more recently by guidance that was issued by NICE in relation to safe staffing of maternity units. So we're in a better position in terms of being able to guess how many we need. That won't help us if the 22% that are over 55 decide that they're all going to lift their pension. I think from our point of view, probably the single biggest thing that would help at this moment in time to keep workforce planning on everybody's horizon would be for both the RCM and the RCN to be involved in the regional workforce planning group, because I do not see how the HR Directorate at the Department of Health can plan for the professional workforce across Northern Ireland without speaking to us.
Okay, I think that's very clear. Finally, before I move on, I noted as well that in your paper again, there were 600 nurses employed across GP practices, and you had referred to concerns about terms and conditions.
Yes, maybe read it.
No, just we're looking at the practice nurse at the minute. There's a couple of issues. Obviously, practice nurses are seen as independent. The GPs are independent employers, and so therefore there are no standardised really terms and conditions for practice nurses. There are a few issues with practice nurses at the minute, so obviously keeping them skilled, because it depends on the GPs whether or not they're prepared to pay for the education and training, and obviously good employers do pay for that. They are an ageing workforce. There is no standardised as such preparation or acknowledgement of standards of education to go into practice nurse posts. So some of the issues that we have there are in terms of keeping them skilled for the services that the TYC would expect to be delivered through the GP and practice nurse role, if you like, and the fact that the practice nurse programme is no longer commissioned from the universities because the employers would not pay for nurses to do it. So there's an onus there on us to look at the practice nurse population with regards to what skills and development they need for the future. If TYC and the GP being the gatekeeper and the person who, and the practice nurses do things like health assessment and signposting and try as well to keep patients out of hospital. So it's all nursing, but it all happens in different places and they have different skill sets. And it is about recognition that workforce planning, again, is not just about numbers, but about skill sets as well.
But there's an obvious issue there where it may become more difficult to recruit and retrain practice nurses if these issues aren't resolved.
Yeah.
Is that
Well,
a
if
fair
they don't
comment?
get the same terms and conditions and supervision, and we now have revalidation, professional revalidation coming in the next 3 years, and they need proper clinical supervision and work to do the revalidation, that could become an issue.
And Fergal wanted on just on this point.
Just on this very specific point, just strategically then, how does the system understand the amount of nurses, and does it audit the work? Does it know what's happening on this side of the wall in terms of GP? Does the mainstream system monitor that, assess it, know what it is in terms of the day-to-day work of nurses and GP
I
practice?
think very much trust and independent sector seem totally different. I don't know that there's anybody that we know, apart from ourselves, that have an overall view of nursing as a whole. I don't know that the department look at that either.
This might be a leading question. Is that a flaw?
Well, I think that's
Yeah.
fair to say. I think it should be all part of the overall workforce planning piece, that all that needs to be pulled together. I think, in fairness, the work that has started in relation to nursing and midwifery workforce through planning through the Chief Nursing Officer, that work has started. We still have some concerns, and certainly our organisations are involved in that from a uni-professional perspective. That needs to dovetail into the regional overall workforce plan, which is where we're saying we're not and haven't been involved to the level that absolutely we need to be. But there's still, as the paper identifies, some concerns about the work in that group.
Okay, thank you.
Thank you. Rosie's next.
Karen Mayogan Carley, thanks very much for the presentation and for coming today. And to refer to the review, one of the terms of reference is to assess progress on workforce planning in support of the implementation of TYC at trust level. And the RCN briefing paper states that you're not aware of any workforce modelling at HSC trust level. And, you know, I know we've discussed that and all of that, but I was going to ask, can you elaborate on the implications of that? So just, have you anything further to add that maybe hasn't already been said?
Yeah, trusts, if trusts were sitting here, they may argue that they are doing that. We would argue that it's generally under the realms of service reorganisation, and quite often that is to do with trying to save money. And I know that might sound a very cynical view, but we do deal with it on a day-to-day basis, where service level or services are being reviewed, and it is to try and take out posts to save money, and also to, in some circumstances, almost reband or downgrade as a way of trying to save money. And sometimes that is put under the realms of workforce planning, and that is totally wrong.
So, I mean, then would you be aware of the trust making any investment? And it seems from what you've said that it's the opposite. But would they be making any investment in the training or retraining of staff to achieve the shift left in terms of skills mix needed to implement TYCs? We've just said that they're looking for ways to save money, and they're probably doing the opposite.
Yeah, and in fairness, I suppose, to the trust, they are in very, very difficult times, and they have to live within their budgets. Certainly what we see in relation to that as well, there are examples, I suppose, where trusts put bids to commissioners, where there may well be good and well evidenced service reform that is evidence-based around patient care, but sometimes commissioners are not commissioning on that basis, and certainly we would hear from the trusts where they feel that commissioning, and we know from Sir Liam Donaldson's recent report the difficulties and problems we have with commissioning, and that's certainly something we wouldn't want to put solely on the responsibility of the trusts. The commissioners have a big part to play in relation to this work.
And do you feel the trusts are investing in leadership and capability development in the nursing course? This is like a different level.
I do a lot of training for senior nurse leadership I do a lot of programmes for that. And last year, I think, from our own point of view, there were, as far as I know, 120 places on a leadership programme requested and commissioned by the Trust, but there was no education budget at the department to let them carry on.
Didn't happen then.
It didn't happen.
So then, really, there's no investment in leadership in reality.
Those ones weren't commissioned.
Right. Okay.
I think it's fair. There are some, but not near enough
What's needed.
to provide for what is required.
Sorry, I think one of the things that we need to remember as well is that we're all fishing from a very small pool. And we talked about there were 65 health visitor places commissioned this year to meet need. But those aren't 65 extra nurses, they're 65 nurses who have come out of trusts. So everything new that happens, maybe new district nurses, they're coming out of a trust somewhere. It's not that we're making more of them. And I think that's some of the concerns that we have as well. While we can move on and we can improve skills and knowledge, it's from the same pool. And the independent sector, we're all fishing from the same pool, and that's causing a difficulty.
And I suppose the same is true in midwifery, where although midwives can and do work flexibly across hospital community boundary, if you're going to move more services into the community, you have to put midwives out there to staff those services. But there comes a level beyond which you cannot pull any more out of the acute service either, because they need them. So there's a piece of work I think we still need to do to look at what that might mean in terms of commissioning extra midwifery places to get midwives in place to follow through the complete shift into the community for women with low risk pregnancies that we would very much like to see.
Okay. Will I go with my own
Yeah,
questions?
sure.
Yeah, okay. The briefing paper expressed disappointment at not being included on the regional workforce planning group, and you talked about that, and the fact that it has not been made aware of any proposals being developed by the group. So how would you assess the department's approach to involving professional bodies like yourselves, the RCN and the RCM, on the workforce planning needed to implement TYC?
Just need to be there.
We need to be there, and I think, the department and officials at the department have not been recently particularly engaging in relation to involvement of organisations like ours and other trade unions. We recently have had correspondence in relation to the Partnership Forum as an example, where a previous minister had given a commitment that the Partnership Forum would be carried out a review regionally, and those terms of reference for the new review or new Partnership Forum were agreed by Minister Poots. And unfortunately now the Permanent Secretary has recently communicated to say that he didn't believe that we needed a Partnership Forum. His view is that the Joint Negotiating Forum is the forum to discuss these issues. We disagree. We believe the Partnership Forum is much greater than a negotiating forum. It is about policy, it's about strategic direction, it's about key stakeholders having conversations like some of the conversations we're having here today. So we are concerned that the current administration and climate is not one where we're being engaged to the level that we should be. We will be constructive partners in this, absolutely, and I think our record speaks for that. We will absolutely challenge, but we'll be supportive of directions that are in the interests of patients and for the public in Northern Ireland, absolutely. And that's why we do find it staggering that we are not involved to the degree that we believe we should be.
And we have a huge body of knowledge because of our direct contact with nurses and midwives at the coal face that we could bring to any arena and present those views to the highest levels. And at the moment, there's no way for those voices to be heard. And we are not all, as the Tory government have us believe, all in this together, because we are not at this moment in time all in this together. We don't know what we don't know, actually, quite often, which is very worrying. And the decisions are being made in isolation and there isn't any discussion. We were told, however, we would receive consultation documents in the same way as anybody else, members of the public, and we could respond to consultations, and that would be sufficient.
It's just hard to fathom the logic behind that. But my final question is, the TYC document stated that a reduction of 3% of the workforce, or 1,620 staff, will be required for implementation. However, the committee has heard from the department that that is no longer a target. So has the department communicated any new target to either of your organisations?
No, not.
I mean, that was a surprise to us, that that's no longer a target. So it's just hard to understand that. So you have no knowledge of that either? Okay. All right.
Yeah, just quickly on that, in terms of the regional workforce planning group, you know, the indication to us was almost that the uni professional reviews would help to shape workforce planning, if you like. I'm assuming you're saying something very different. You know, is that enough? Is the uni professional reviews enough?
No, a uni professional review is very helpful, where we sit down with the Chief Nursing Officer, who's our professional lead in the Department of Health, and we discuss what does the future look like for nursing and midwifery, and what type of nurses and midwives do we need, and how many of them do we need. But at some point in time, then all of the other health service professions need to sit around a table, because I could say we will need midwives out in the community doing ultrasound scanning for women, but we will need sonographers to help them with that, or to train them, or to send the people to for a second opinion. We also need to work with community pharmacists if we're going to send women in that direction. So we need to know what workforce planning looks like right across the piece. And for an HR, for that to be seen as purely an HR function really isn't good enough. I think that the professions are doing their best in the silos that we're forced into. But I really think we need to be round a table at some high level, saying, if you're going to do that, then what will the impact be on another group of staff? And we're not having those discussions, and there's no arena for having them.
We need more than a document. We need more than words on a sheet of paper, to be honest.
Okay, thank you for that. You're finished, was it? Yes. Kieran, next.
Chair, thanks very much indeed. Thanks for your presentation. Last week I said that I'd spent 3 hours in this room. It was the worst 3 hours of my time in Stormont. And there were presentations from BMA, Royal College of GPs, and they were saying exactly the same as you're saying yourselves. And I'm about to spend another 2 hours being further depressed by what you've said, but I accept that it's the truth as you see it on the ground. And I do hope that the people that can do something about it are listening to this conversation today, because unless and until something drastic is done to improve the situation, we all are going to suffer the consequences. Having said that, let me put on record my total and absolute admiration for the work of the nursing profession throughout Northern Ireland for the years that they have, the work they have done and continue to do, despite, I think it was yourself, Breda, said, or maybe yourself, Gar, that nurses were at breaking point, and we can understand that. But unless and until, can you tell me this? Do you reckon that the people at the top know what they're doing? And we talked about transforming your care. We talked about that last week, and I think I used the term "dead in the water." Now you used the term, "Is it a viable strategy?" It seems to me that you people are saying that it is not a viable strategy. It's dead in the water, and where are we going from here? Now we did support transforming care, as you said at the time, but unfortunately the main author of transforming care, I don't know where he's gone, left everybody fighting to move it forward, and we certainly, from what you're saying, we're not moving it forward at all.
I think this is one for Gareth, because because maternity services are a very small, discreet service, and as I say, work had already started on transforming the maternity service before transforming your care came into being, and that work continues by way of our own wee mini TYC, which is the Northern Ireland Maternity Strategy, which runs until 2018. So we actually have a pathway that we're on and are following, and we are doing it at this moment in time absolutely within existing resources. That's not to say that there might not be resource implications further down the line, but in terms of mainstream transforming your care for ill people, that's definitely Garrett's department.
Yeah.
Well, I think it's fair to say, and we all know, that this is very complex. It's they're very challenging times, and they're very challenging financial times. And we all certainly have a responsibility, and organisations such as ours obviously have a responsibility, and we're very clear about what that is. I think if it was easy, it would have been sorted long ago. What we're doing is highlighting the issues, highlighting concerns, and they are very serious concerns.
But what you've said, there doesn't seem to be anybody listening that can do something about it.
Well, I think what we would like to see is more honesty in the system. We would like to see where things aren't going to be able to be done, that people admit it, at whatever level that they're at, and being honest with the public and being honest with organisations like ours. I think absolutely there are very difficult decisions to be made that go to the heart of politics, let's face it, as well as everything else. And that's the climate we're in. I think we do owe it to the public of Northern Ireland to show we all have a responsibility of leadership here. And we're not here today to scaremonger or to raise concerns. We know absolutely there is fantastic work going on in the HSC day in, day out. We know the work that is going on, and we would not want in any way to come here and say that everything is doom and gloom. We know that a lot of patients get fantastic care. But the downside, and what we're highlighting here today, are real risks and real issues and warning signs that if we all don't sit up and listen to, they're going to get an awful lot worse. And we all have to show some leadership in it.
Yeah, and you did mention that patients could be at risk because of the situation. That is a critical statement, because nobody wants to see patients put at risk at any time. Could I ask you, Garrett, on your briefing paper, states that the nursing and midwifery training budgets have been cut by the department over recent years. Are you aware of whether the department or the Regional Workforce Planning Group has any plans to change this in the near future? And it seems to be not very optimistic.
Well, the education budget has been eroded. Nurse education budget, post-pre and post-reg, has been eroded over the last number of years. Last year, the education budget wasn't set.
Apologies about the background
okay.
noise. We're trying to. I think it's a phone, somebody's phone, so can people just check their phones? Sorry, Rita, go ahead.
Okay,
Sorry.
okay. Last year, from the RCN is also a provider of nurse education, and we provide quite a bit of post-registration nurse education, and usually it's commissioned by the Department of Health. And last year, none of our programmes were commissioned due to the fact that no nurse education budget had been set for pre-reg education, and it's continuously. Now, we don't know what it's going to be this year yet, and we're in April. And we don't know what the pre-reg nurse education budget is going to be.
We are aware that there's between 20 and 30% of student nurses who qualify in Northern Ireland don't end up working in Northern Ireland. And we know that there's a school of thought that thinks that that needs to be addressed before we would increase the numbers. We don't believe so. We believe the numbers need to be increased. We need to understand why there are such high rates of people qualifying as nurses and then leaving Northern Ireland. Absolutely, we have to understand the reason for that.
If I could just add to that as well, I think if you look socially among young people now in all walks of life, it seems to be the recognised norm that they go away for 1 or 2 or 3 years and then come back, particularly our young doctors and nurses. So that might be something that when we're doing workforce planning we have to factor in, that we lose them for a couple of years, but we have to make it attractive for them then to come back with the added knowledge and skills that they've gained elsewhere. So it is a fact of life that that's what our young people are doing now, because the world's so small, and our nurses are very employed, particularly nurses in Northern Ireland are sought all over the world because of their training, and they can get jobs anywhere. And they are actively being recruited in recruitment fairs from America, Australia, England in particular would take every single nurse we trained.
Again,
if
it's
they
down
could.
to incentive. Young nurses are leaving for incentives to set up somewhere else. Again, the knowledge and experience can come back again, certainly. But the like of myself that never left, stayed here, it can be very difficult when you're working on the ground and working in that front and you're left with a very inexperienced staff. It can be very difficult.
Yeah. Well, thanks very much for that. I mean, that was the next question. Is there anything that can be done to retain those highly qualified nurses to stay with us?
Yeah, and we certainly have to look at some of the recruitment processes within the trust and how nurses are being recruited.
Yeah.
The career in terms of choice of clinical area, that has been eroded. The professions in terms of ward sisters being able to, I suppose, recruit staff to their own wards, all those processes have been eroded. We also have to look at career pathways, what career options nurses have whenever they enter and into their qualified career as such. So there are a number of things that need to be done in relation to that, absolutely.
Right.
But one of them would be ensuring that where you work, you've got safe numbers of staff, that you're not left. You know, a lot of our nurses would carry or would talk about the concerns they have of the risk to their registration in you know.
Well, we heard very recently where the nurses cannot leave their work. They stay on for an hour or whatever it is, an extra hour and a half, without pay to show their dedication to the patient, and that's absolutely fantastic. But it's unfair to the nurses that have to do it. A couple of quick ones, Chair. The Regional Workforce Planning Group and the Trust, have they any strategic plans in place to reduce the use of bank nurses and to create more permanent posts?
Well, that would be part of the normative staffing arrangements, and that is work that's really just beginning. We have been given some assurance that expectation that would be the first phase would be complete or implemented by the end of the first quarter. We think that's optimistic considering some of the recent communications and things that we're hearing from employers, but certainly that would be part of that.
Right.
And there isn't any agency midwifery in Northern Ireland at all, but a heavy reliance on bank midwives. Generally, these are midwives who already work part-time in a trust, and if a colleague goes off sick, then they ask all of their part-timers to work additional hours to cover for those missing shifts, or they ask their full-timers to work overtime to do it, but they're highly reliant on the goodwill of their staff to cover any sort of absence, and whether that's a planned absence like a maternity leave or long-term sick leave, or whether it's an unplanned absence like somebody goes off sick or bereavement leave or something like that, highly reliant on the goodwill of their staff to cover.
Yeah, and finally, you mentioned, I think all of you mentioned the rural nursing and the difficulty. I think you used the word district nursing. Is that the same thing anyway? Is there anything that can be done to provide more of those? What about the use of incentives to recruit the district nurse? That's the nurse that goes out around the country, the rural areas.
I think it's back to the point again of acceptable levels of staffing and training, and having enough places commissioned and supporting people to be released to do that. That training is the key to that, because as you can see, there has been a reduction in that. But absolutely, giving the appropriate level of banding, as we call it, for the skills and qualifications that these nurses have, and sometimes that does not happen.
Well, thank you very much, and keep your head, go up, and don't let them get you down. We're all behind you. We're all behind you. You know your job. Thank you very much, Chair.
Thank you, Kieran, for that. Pam?
Thank you, Chair. Thank you for your presentation. One of the terms of reference for this review is to examine the extent to which workforce planning is taking account of recruitment issues for particular geographical areas. Can you tell me, is this an issue for either nursing or midwifery? And if so, how do you think it can be addressed?
I think I'll use one example, and it's around children's nursing or paediatric nursing, where you find there are obviously a limited number of places on an annual basis. But because of regional recruitment, you find that Belfast tends to recruit most of those nurses who come out with their paediatric qualification, and that can certainly leave some of the hospitals further out of Belfast, and particularly in the West, having great difficulty recruiting. I think the profession needs to be in charge, would be, I think, the right word to use in terms of recruitment processes within and for the profession. It shouldn't be based on solely HR processes. We need to have solutions to those situations where we have difficulties recruiting, whether it be in rural areas or in specific specialties. We absolutely need that within any proper workforce planning, and the recruitment process needs to be tightened up to allow that to happen.
And I suppose for us, midwifery is such a popular career option. We don't have the same issues with newly qualified midwives going away. They might go away if there isn't a job immediately available here in Northern Ireland for them, but anecdotally we know that within a year they're nearly all back in Northern Ireland, and then they stay here, and then they stay in midwifery to the end of their career. So we don't have quite the same problems as nursing. Neither do we have a problem recruiting midwives to work in any particular geographical location. Where we do have a problem is when very senior midwives retire. It can be very difficult to get people with enough skills and experience and training and leadership development, as Rita has pointed out, who are willing to step up and take that post. We have one post in the South West Acute Hospital, a very senior midwifery post. It's been vacant for 2 years. It's been advertised nationally 3 times. So it's those posts, and that post is absolutely needed to provide leadership and strategic direction to the midwives and the maternity service in the South West Hospital. We cannot fill that post, and we don't think it's the geographical location per se. We think it's the fact that it is a post at that very senior level. So every time I hear that a senior midwife somewhere is going to retire, I just feel a bit sick. I think, oh Lord, I have to find another one now. So it's that's the bigger challenge for us.
And sorry, just on that point, because as a profession in midwifery, you said the gender statistics there, but in nursing it's 92% female, and you primarily have a young female workforce in this as well. So there are those issues in terms of mobility of staff that are greatly reduced as well, that need to be taken into account of when recruiting staff. Okay,
thank you. And another question quite similar, but another of the terms of reference is for the to examine the extent to which the workforce planning is taking into account the desirability of 7-day working. We know you do 7-day working, but is this an issue for either of you? And any suggestions, if that's the case, how those can be addressed?
Well, at the minute it's a 365-day a year, 24-hour-a-day service, so there certainly is 7-day a week working. It is incentivised to some extent in terms of if you work between 8 p.m. and 8 a.m, you will be paid an additional rate for working those unsociable hours, and if you work a Saturday or a Sunday again, you will be paid an additional rate for working those unsociable hours. And if you're on call, you get, I might be wrong, but it's about £12 a night, and you go on call from 5 p.m. one evening to 9 a.m. the next morning, and you can't go out really, and you can't have a drink, and you can't let anybody else have your car in case you need it, because you get called, and you'll get £12 for that. So there is at the moment some incentivisation for people to work out with normal working hours. I know there are some discussions across the water about let's do away with that incentivisation. I don't think we would have a health service. I don't think any nurse or midwife will provide a 7-day a week, 24-hour-a-day service if they are being paid the same rate for working during the day as they are paid for working at nights and weekends.
From our point of view, it's exactly the same. Obviously, there is a lot of evidence, empirical evidence around patient safety, and there's no doubt about it. Nobody would disagree that if you are admitted to hospital on a Saturday, that you're level of care should be the same as if you're admitted another day during the week. And nobody disagrees with the concept of having 7-day services. Nurses are used to that. We provide that and have done over the years. But any increase, there needs to be a commensurate increase in the workforce required to do that, and that should be the same for nursing as it would be for any discipline. But also on the point about seniority, sometimes we hear that it's about putting senior doctors on at weekends. We also have an issue about senior nurses on at weekends. Because of the banding issue with nurses. You find that trusts put on band 5s, who are the most junior nurses in our wards to staff wards because it's cheaper. And what we would be saying is we need senior staff who are properly remunerated 7 days a week. We also, as I said, agree with it being rolled out for other professions, but not at the expense of nurses, and by trying to take away unsocial hours payments from nursing to pay for others to do this, we would find that totally and utterly unacceptable. But as a principle, absolutely signed up to it.
So the incentives for the unsociable hours, is that an additional payment, or is that built into the working?
There's an additional rate for Saturday and Sunday and bank holiday and night work. But that is part of the agenda for change, contractual terms and conditions.
And you're saying that there is an issue with the bands of the nurses that are there at the weekends?
Yeah,
at a time when
many
fewer doctors as well.
Most of our wards and departments are staffed with band 5s. They're the most senior people on at weekends in most of our hospitals. We may have 1 or 2 band 7s covering a whole hospital.
Midwifery is slightly different. Most midwives are on a band 6, which is a slightly higher band, and it reflects the fact that they are required and do work anywhere and everywhere. If you're working in a maternity hospital in a ward with women who've already had their babies and the labour ward gets busy, they just lift the phone and say, we need you in the labour ward. If you're working in the labour ward and the admissions unit gets busy, they'll ring you and say, you need to come down here. So they do work very flexibly. In fact, if you're working in the community and the labour ward gets busy, you could get a call to come in from the community and work in the labour ward. But there is, as I say, a cost to that level of flexibility, and it's in terms of maintaining the goodwill of the staff, and it's about recognising the hours and the effort that they put in, especially out of hours, especially that period of time between 8 at night and 8 in the morning, and Saturdays and Sundays.
That's vital importance of midwifery, because
it's
no amount of planning will decide.
No, not at all. They come and they're ready, that's it.
Exactly. Thank you.
Thank you. And just on that point about banding, I'm just noting, again, it's in your paper, but I mean, the highest percentage of headcount is band 5 across all of the trusts. And I'm just looking in terms of the Western Trust, there's no band 6 nurses at all.
Yeah, although there is a higher percentage of band 7s, which we would welcome. Some of the trusts who have banded district nurses as band 6 effectively should be band 7s in our view. So yes, there is a discrepancy, or certainly an inconsistency in terms of the different organisations around that.
Okay. Okay, thank you. I just picked up on that. I wanted to raise it with you. Michael, next.
Okay, thanks, Chair, and thank you for the presentations. As Kieran has said, we had a couple of presentations last week which were fairly sobering, and I have to say I think your presentations have been equally sobering as we look into the future. Could I begin with the midwives? And I know you'll correct me if I'm wrong, but as I understand, memory tells me that your standard used to be, or I think, 26 babies per midwife. Is that right?
It is about 1 midwife to every 28 babies.
And that allows you 1-to-1 in the labour ward?
It does.
Has that standard been maintained?
Yes. But it has been maintained at a cost, because what happens is, in order to ensure that every single woman in labour has a midwife with her, the women who have newly delivered are basically seen as the Cinderella service. If you have 20 women and 22 or 23 babies, bearing in mind there are quite often twins in hospital, on a postnatal ward, and you start the day with 3 midwives and a maternity support worker, you could end the day with 1 midwife and a maternity support worker, because your other 2 midwives have been called away to the labour ward to meet that standard of one-to-one care for every woman in labour, because that is absolutely crucial, and that is the critical point where that care is needed. But that then means you have these 22 mothers and their babies who are being cared for by one midwife and maternity support worker, and that's not good in terms of trying to increase, for example, our breastfeeding rates. Women need support, and a lot of these women will also have been delivered by a caesarean section. They need normal post-operative care that anybody needs. So the pressure is just shifted somewhere else. But yes, we do have, and we're very proud of it here in Northern Ireland, we do still have one-to-one care for women in labour.
Okay.
But the pressure is just being shifted elsewhere.
And also then you mentioned Downpatrick and Lagan Valley, and there was a concern that a standalone outside of an obstetrician-led wouldn't be as popular. Have those proved to be, has the demand been there that we anticipated for Lagan Valley and for, as opposed to Craigavon where you have the obstetrician-led on site?
The demand has plateaued in both Downpatrick and Lagan Valley, but there are about 200 to 300 women a year who go to Lagan Valley who otherwise would be forced to travel to Belfast. There are only about 80 or 100 women a year who go to Downpatrick, but again, that's 80 or 100 women who then don't have to travel to Belfast. They're staffed in different ways. Lagan Valley has a midwife on site 24 hours a day. During the night there's a midwife and one maternity support worker. That's it. Downpatrick don't have anybody on site at night. They have a midwife there until 8 o'clock, and if a woman rings to say that she's in labour, the midwife who's sitting at home on her £12 a night will come in and meet the woman and deliver her in the unit. So the costs of maintaining the service are minimal, because those midwives would be there anyway to provide the care, the antenatal care during pregnancy and postnatal care to women who've already had their babies. And if I said to you that 17 whole-time equivalents covers an area that goes from Kilkeel to Carryduff and from Ardglass to Castlewellan, and the 17 whole-time equivalent midwives provide antenatal care to every woman in that area, even if she's not going to deliver in that area. They see her during her pregnancy, they see her when she comes home with her baby, and they deliver the women in both Downpatrick and Lagan Valley as well. You can see the extent of the flexibility of the service that they provide there.
Okay, thanks for that. So the workforce is around 1,300.
Mm-hmm.
Is the sense of it that that's roughly adequate, or do you need more? And also then, how do you maintain that workforce with about 25% liable to retire within the next 5 years if it takes 3 years to train through a dedicated degree course, or 18 months for RCN registered to train, and bearing in mind when you take that course you're depleting the nursing workforce. Mm-hmm. So clearly you need to be on the planning. I think that's a given, both for RCN and for midwives. Do you have a sense of what your recruitment needs to be as opposed to where it is now? You know, it's work out what the problem is, and then after that you work out how you address the problem.
We think at the moment that midwives largely, by and large, are in the right place, doing the right things, because that's important too. They shouldn't be doing clerical jobs. They shouldn't be portering. They shouldn't be doing stocking up of supplies. There are other people who are employed to do that, or should be employed to do that, to free the midwife up to do midwifery. So we think we just about have the right numbers at the minute. We think they're mostly doing the right things in the right places. The worry is about the future, and we watch it like a hawk. And we meet with the Chief Nursing Officer once a year as a nursing and midwifery group to look at education commissioning for the next year. But in between times we also meet with the midwifery advisor at the Department of Health, and we try to work with the heads of service out there, and every so often we ask them how many of your staff are planning to retire in the next year. So we try to keep ourselves sort of a year ahead. But your point about the length of time it takes to fill gaps is well made, because we did have a situation some years ago in Craigavon where there was not a single unemployed midwife in all of Northern Ireland, where they had this domino effect and lots of people retired, and they were left with a huge gap, and they had to recruit midwives through an agency from Glasgow for a week at a time, fly them over, give them accommodation, a week's work at agency rates, and then fly them back to Glasgow. So at that time, I think perhaps you were the minister at that time, extra money was given to Craigavon, and we pushed 12 nurses, sorry Garrett, we stole them from nursing, through the 18-month education programme to get them trained as quickly as we could, because although Northern Ireland is an attractive place for people to come and do agency work, it isn't all that attractive really to people from elsewhere in the UK to come and settle permanently. Certainly for midwifery, I'm not too sure about nursing. The traffic all seems to be one way, the other way. So we have developed the 3-year midwifery training programme, which is the route into midwifery for most midwives, because it's shorter than doing 18 months or 3 years nursing and then 18 months on top of it. But we also have the 18 months that if push comes to shove and we need midwives in a hurry, we can rob our nursing colleagues and get them through Queen's that bit more quickly.
Okay. Thanks for that. And as far as nursing is concerned, we heard last week from GP saying the practice nurses, that workforce severely stretched, and as they keep getting more and more things to do, they need more and more practice nurses, and they're not available, and so on. So we got that message. We're getting the message here also about TYC and community nursing and how difficult that is. And in fact, TYC is basically stopped, not least because of that difficulty. We also hear, and the nursing workforce is what, 16,000?
Roughly, yeah.
Roughly in the system. And we've heard about nursing staffing levels in wards being at unsafe levels. So effectively what we're looking at is, and that's the main bulk of the workforce, if we're looking at unsafe levels in places, I mean, we can't ignore that, put our heads in the sand about that, because patients will come to harm. We also have the problems in practice nurses, and we have a problem in community nursing. Do you have a sense, and I know you say you're not in the workforce planning group, and that is a given that you should be in there, do you have a sense of how many nurses we need to be recruiting? Bearing in mind that we do offer brilliant degrees for our nurses. I'm aware how attractive they are of the big hospitals in the southeast and other places overseas, just how keen they are to recruit our nurses because our nurses are so good. Where do we need to be as far as that? Because if you work out how many nurses you need to recruit each year, then it's a simple sum working out where the money needs to be. Because my view is that we're in an emergency situation, we need an emergency plan with an emergency fund. So trying to put all that together. Where do you think we are? We're 16,000 roughly at the minute, but you've told us here about community, we know about practice there. Putting all that in the mix, and I know you'll have a rough idea.
I honestly couldn't put a figure on it. I couldn't put a figure on it. I'm not sure, Rita, if you do. I think it would be unfair to even stab a guess, to be honest. I think it's about the normative staffing, the programme for that, and rolling that out and seeing where the deficits and gaps are.
Yes.
But it's also about the future planning, and as I say, as we've pointed out and have indicated in our paper, one of the areas that is neglected here is in the independent and care home sector. Where
I
our
was
older
setting
people
out to one side because that's not
But
direct.
I don't think we can ignore that. I
understand that, but I mean,
if we do, then we're draining that sector. But certainly, it's something that needs to be done sooner rather than later.
Yeah.
In relation to the community setting, and also mental health and learning disability, sometimes there are areas that get forgotten about as well. There are areas that require, careful plans.
Yeah, it's just when you say you need, and I agree with you, need more students, it's roughly how many more, and do we have the capacity within the universities to train? Where are those numbers? Where have they been over the last few years? Are they going down? Are they going up? Or?
Well, they're going down, as we said, it's reduced by 9%.
Yeah.
The numbers, I think the capacity issue in terms of universities could be addressed if they were commissioned to take, for example, another 10%. I'm sure they could deal with that. But once again, that's a funding issue, and a decision needs to be made by the commissioners in relation, and the department who commissioned this, to put the funds to it.
Absolutely. The 10,000 bays, the independent said it's a sort of a standalone, but they are heavily dependent on income from the department, isn't that right?
Absolutely.
A tariff per patient.
Yep.
And that tariff, they would say to that tariff per patient has hardly moved in a number of years. So they're finding it very, very difficult to pay the rates for nurses.
Absolutely.
Sorry, also within the independent sector, the patients are much more complex than they were probably when the tariff was set. And a lot of those patients that are being nursed in the independent sector would previously have been nursed in acute medical wards. And if you, we did a lot of work with the independent sector home managers, and they would say to you now, it's extremely difficult to give those patients the care that they require with the complexities that they have and their complex nursing needs. They're not, they're not personal care needs, they're nursing needs, and they are struggling with the numbers of nurses that they have to give the quality of care that we would expect for our older vulnerable people, but also the quality of care that our QIA are inspecting them against.
Yes.
And there are huge issues in that sector about being able to recruit and retain good, high-quality nurses. There's a big reliance in those. One of the independent nursing home managers that I spoke to, of her 7 registered nurses, 7 of them were from all different countries. 7 different languages were their first language. So you can imagine, in terms of our older people's cultural needs being met, that's a huge issue. You can imagine trying to develop a team and a vision for your service with 7 people whose English isn't their first language, who are trained in totally different ways. And that sector has become so reliant on particularly nurses now from Europe, because we have the ability to sort of walk in and out of jobs now with European. That brings huge issues for our older, more vulnerable people. And if we don't look at workforce planning for nursing as a whole, well, they're going to be left, and our older people are going to be left being looked after by people who don't understand their cultural needs.
10,000 beds, that's a huge population.
It's huge, yeah.
Of frail elderly.
Yeah.
With, as you say, complex needs. Could I finish off just, because one of the things community nurses are supposed to deliver is the nutrition. And there was a nutrition policy. Where are we with that, about ensuring that our care in the community through our community nurses and so on?
The nutrition strategy is actually, it's a regional strategy, and it's right across all the professions. And the strategy identified that all patients should have a nutritional assessment if they're in any kind of connected in any way with the health service. They should have a nutritional assessment. That would include older people who are attending GPs, and it's the use of a must. It's called the MUST tool, and it's a nutritional tool. That's not specifically the role of the district nurse. That is across whatever profession is the key worker, if you like,
Where
for
is
that person.
Policy?
I think it's being rolled. It's been accepted and it is being rolled out. However, again, whether or not there are the resources to actually implement it, if a patient is being looked after in their own home and they see a district nurse, well, they should do the MUST. But if they're being looked after, for example, and it's domiciliary care worker, I couldn't guarantee that it would be done, or if they're seeing their GP, whether or not the GPs have taken it on.
The Meals on Wheels service has been greatly reduced over the number of years because of different things, which is not.
Well, we know 42% of people who come into hospital come in malnourished, and we know that has a huge impact on our older people. So the nutrition policy was to try to prevent.
It's not just meals and wages, diet supplements and so on.
Well, it's actually, I suppose it's acknowledgement of the importance of nutrition in older people. And the plan of that policy was to try to prevent malnutrition, because malnutrition leads people into hospital. But where we are with the implementation of it now, I wouldn't be 100% sure, but I know it's across the piece regionally, and it is across all professions.
Okay, listen, thanks for that, and the best of luck.
Thank you.
And we will take very much on board what you've told us.
Thank you, Michael. George?
Thank you, Chair. And could I thank the team for their presentation? My question be to Breda, basically, I'll just read it out here. One of the terms of reference for this review is to examine the extent to which workforce planning is taking account of gender mix and the associated work patterns. The majority of the nursing and midwifery workforce is female. Our current approach is taking this into account in terms of part-time contracts or planning for maternity leaves.
This is a huge issue for us.
Yeah.
There are just about 1,300 midwives in Northern Ireland. Only 2 of them are men. And something in the region of 70% of them work part-time. So from a trade union point of view, I could say it's great we have flexible working right across the system and women are able to achieve some sort of a work-life balance. But for somebody trying to manage the service, to have a service that is 70% part-time brings its own challenges. If then you take out the 65 midwives who are pregnant at any given time, out of that 1,300, and then you add in sickness absence rates, which vary across trusts from anything from 4% to 8%, you'll see that there's a bit of a stretch there to make the number of staff go round. As I said earlier, we're highly reliant on bank staff to fill the gaps. So you'll find that a lot of the midwives who work very part-time, so less than half the week, will also be on the bank. And it means that although they've chosen to work 18 3/4 hours, say, to get a work-life balance in any given week, they could be working 35 or 36 or 37 hours. So that causes stresses on women who've made a conscious decision to try to balance their work and their home life, bearing in mind that at one end of the spectrum they're having babies, and at the other end of the spectrum the over 55s are likely to have caring responsibilities. So making a conscious decision to reduce your working hours, which then gets negated by the need for you to be at work to cover for somebody else who's off sick or off a maternity leave or has been bereaved or whatever happens, or even just to cope with an unexpected surge in demand. I think that brings its challenges as well in terms of managing a service. But I will give credit where credit is due and say that the HSE is one of those services where it is possible to work quite flexibly, and there is a high degree, certainly in midwifery, I'm not so sure about nursing, of ability to go and say, it suits me, I've been left widowed or separated and it suits me to work night duty, can you put me on night duty for 6 months? And by and large the service will accommodate that. Can you put me that I work all weekends because then my husband can take care of the children? We can do that as well. So it makes it a very attractive employer from that point of view. And I think by and large over the years, with a lot of cooperation from the trade unions, that the health service has moved to this point where it is a very attractive employer in terms of, as a woman trying to work and balance your work-life balance. But it's a way also of recognising all the investment. We've just heard chat about how long it takes to train as a nurse or a midwife, how much money is invested in that, and then developing those skills and experience. And it really would be a very stupid policy to lose all of that just because you can't be flexible and accommodate somebody's request to work specific hours.
Just maybe a small supplementary question to one of you. It's in relation to the nurse prescribing situation, where do you think there's enough flexibility for nurses?
In nurse prescribing,
Yes.
and, as
Yes.
prescribers, and by flexibility, do you mean
whenever they're training, or whenever they're maybe at university and so forth, they may be being asked as well, to carry on their ordinary job?
Yeah, certainly. In my clinical practice, I was a nurse, an independent nurse prescriber, which is a recordable qualification on the NMC. It's a 1-year part-time programme. It's probably the most demanding academic programme I ever undertook, and it is something that, in terms of reward, it allows practitioners to obviously take on roles in relation to medication prescribing that previously would have been medical staff who carried out. It's one that absolutely, I think, in terms of support, as much support that can be given to individuals undertaking that programme, the better. I think there is an issue sometimes in terms of how those individuals are then allowed to practice whenever they go back into their workplace, that some employers may not then have either roles for them and remunerate them to the level that they should be remunerated for having underwent such a difficult programme and been successful in getting the qualification. Sometimes I believe that we believe that those people are underused in the clinical area, but they must be properly remunerated and facilitated, absolutely, whilst doing the programme, but also whenever they have the qualification to be able to practice at that level, because it benefits patients. That allows the service to be able to be developed that can free up medical staff to do other things and to provide better access for patients or more timely access for patients for certain services. So, absolutely.
I think there's flexibility, clarity in it.
Yeah, I'm not sure, I suppose, what you mean, because a nurse prescriber can come from lots of different areas. It could be somebody who works in an emergency department, it could be a nurse specialist who works with patients with diabetes. So there's a whole gambit of areas where nurses who are prescribers, independent prescribers, work. In terms of flexibility, I'm honestly not sure that. I suppose
when they're doing that training and trying to do their own work as well, is the trust allowing them, enough flexibility?
Yeah, well, personally, I haven't heard of anybody coming to us saying that they are not being supported by the employer. I think the difficulty is it is a very difficult course to do in terms of academically difficult programme. So any support that can be given, the better, obviously. Don't know if you want to add anything to that, Rita.
Thanks very much.
Okay,
Thank you.
George Paula, did you indicate it? Okay. Fergal?
Yes, just one point. I think a lot of issues have been covered very comprehensively, and thank you very much for your contribution this afternoon. A lot of the buzz, or a buzz term, if you like, within the health services around the need for innovation. What do you understand innovation to be in that context? And are there other innovations, either through workforce practices or technology, that you'd like to see that would assist in your work?
I suppose from midwifery we could say that innovations are largely led by women, because women will come along and they will say what it is that they want, and the challenge is thrown up to us to develop a service that meets those needs. So that has been certainly our biggest driver over the last number of years. From a trade union perspective, I suppose innovations are about learning from good practice from other places. If you have a recruitment or retention problem, somebody else surely has had the same problem, and what did they do to tackle it, and could we replicate good practices from anywhere else? And I think that is where we miss the partnership forum so much, because previously we could have sat down with a group of employers and the department officials and the trade unions, and we could have bounced those ideas around each other. If we have a particular issue, we did one about tackling violence in the workplace, which was very successful, but we did it in partnership and we learned from others, and then we put that into practice, and that was definitely a brilliant innovation. So, Cara.
If I could just, as nurses, we're always innovators, because you learn from the very beginning of your career to be a problem solver, and where you see problems, you identify a solution and you fix it. And so by nature, the nursing profession and midwifery would be innovators. What I would say to you is, it's very difficult to innovate if you don't teach people the skills of how to get the idea into a change management programme and practice. And there are skills that can help you to do that. And I think that, again, we're back to the whole idea of, there are programmes that would help nurses or midwives or doctors or whatever take an idea, a creative solution, and bring it forward into practice. But that, again, requires a skill, and it requires education, and it requires somebody to get the time out to go and learn how to do that. And those are the bits that are missing, because there's lots of really good ideas out there, but nurses will say, I don't know how to get my idea into practice. First of all, nobody asks them. And what we would say is, if you want to know what will work, you should ask the people who work on the front line, because they could tell you. They have got lots of ideas, but nobody ever asks them. And what happens then is somebody else comes up who doesn't know or understand the service and implements a solution that doesn't work. And then the nurses and the midwives will say, well, I don't know why they did that, because it's not going to work. And we could have told them that from the beginning. So there are, on the one hand, we're asked to innovate, but nobody asks the questions, because we could tell them very clearly. But there are also then skills that you require to be able to get your idea into practice. And again, we're back to the idea of post-registration education not being commissioned to bring the innovations to practice. So what I would say, innovations are done to us, not with us, or you know, together. They're done to us, and they don't work.
And just to add one very quick point on that, I suppose it is, and we tend to see the culture we're working in now as very risk averse, and I think rightly so. You know, healthcare is never going to be risk free. There's always going to be an element of risk with it, but we can sometimes get to the point where risk averse. Innovation, true innovation, does require an element of risk taking, albeit managed. But it's all about a culture of leadership where those innovators can flourish, and certainly, you know, the Royal College of Nursing is not found wanting in identifying those with our Nurse of the Year programme. Every year we identify numerous numbers of nurses who are working way and above the call of duty with innovative solutions. The frustrating thing that we find from that is that those innovators, when it comes to the pieces of work that they have done, isn't replicated, or commissioners or even the employers don't take that forward and roll it out further. We have numerous examples of where there's fantastic work been done in a particular area, but it doesn't seem to be replicated for whatever reason. And what we would be asking is for commissioners and employers to really take on board some of those innovations and start rolling them out as part of core business, and not just as, oh, this is something innovative. And a lot of them show real benefits in relation to cost effectiveness, not just patient outcomes, absolutely, and of course that's ultimately important, but have real cost efficiencies associated with them, and they're the things that absolutely innovation is all about.
Okay, thank you very much. Thank you, Chair.
Thank you, Fergal. Okay, just a point, 2 points to clarify, maybe just before we conclude. One of the terms of reference for our piece of work was about the proposed shift left of the 83 million from hospital services to community services, and whether that had been modelled and planned for. And certainly in the College of Nursing briefing paper, you had indicated that progress is slow, very slow. And in terms of community nursing, you'd pointed out that numbers had actually declined over the last number of years. Again, and you know, you may have answered this question, but I do want to ask it directly. Are you aware if the regional planning working group is even looking at that as an issue?
I believe it is,
Okay.
is looking at that,
Okay.
absolutely. I'm not aware, personally, I'm
Yeah.
not aware of the detail of
Okay.
that.
And, you know, just in terms of, I know that you had referenced the normative staffing work, and you had indicated that that would be, needs to be in action in going forward in relation to the next phases of it, and that phase nursing and community settings was phase 3.
That's right.
Behind nursing in acute medical settings and nursing in emergency departments.
Yeah.
So I'm thinking maybe bluntly, you know, is that an example of the department failing to prioritise community nursing?
Yeah, certainly. Rita.
I sit on the steering group of the normative staff, and to be fair to everybody, the reason that was phase 3 is because we struggled to know how to do it. We struggled to know how to actually identify the numbers of district nurses needed, because if you look at every single trust has a different model, and some are called community nurses, some are called acute hospital at home, some are called complex needs case management. There's a different model in every trust, and it was very difficult for us, and there's no modelling actually that we can look at either in England or Scotland or Wales even to say, well, that's a model we could take forward. So we have nearly, within that work group, have had to nearly try to design our own tools to try to find out how to look to see how many we need. It's not that the will's not there.
Yeah.
It is a very difficult service to try to model against.
And
It used to be it used to be numbers per population, one district nurse per numbers of population, but that doesn't work.
Okay, and Garrett, and then...
Yeah, just one additional point, and a lot of it around, a lot of the information that the medical and surgical staffing levels are based on, it's empirical research. There's a much bigger and wider empirical evidence-based publications in the Lancet or in Forecast, European, worldwide research that indicates or links the number of nurses staffing to patient mortality and morbidity. So that's what that's based on. It's empirical research. Unfortunately, there's a deficit in the research in terms of community and district nursing services. So it's more difficult to have a framework that can do that. So that's why it's probably a little bit down the line.
But Chair, does not get right to the heart of this? Because it links back to Michael's question about if we don't know, then how do we provide? And if we don't know and don't provide, then they're not going through the front door of primary. They're going straight from home into A&E, malnourished or whatever. That work, for me, Chair, has got to be at the core of this. And I'm very frustrated that 3.5 years after TYC, they're only thinking about maybe doing something around this now.
Well, to be fair, they're not thinking. I mean, they have been looking at. There's a lot of work been done by the PHA and by the chief nurse in the department, trying to look and gather up the information that we need. So, we're nearly there, I think, in terms of a model to look at staffing levels within district nursing services. But that, again, we have to think about the other models that hang on district nursing, and what those look like as well.
Yeah, but some of that work's only been starting to be scoped out.
Yeah.
Okay, can I thank you all for your attendance and detail and honesty, and obviously I think as members collectively share the urgency of addressing workforce planning adequately in relation to the delivery of the policy shift, and have individually reflected concerns around the delay in processes to do that. We will certainly take on board the recommendations that you've made in and around the normative staffing processes, the pre-registration issues, and indeed the participation in the regional workforce planning group, and we'll reflect on all of that, and we'll be making our own recommendations to the department. So thank you for your attendance today.
Thank you.
Okay, members, moving on.
Chair, can I just raise 2 points? They're linked points, and if you want to advise me to ring them up under any other business or matters raised. But I've just come from a conference, and it is linked to this, and it's the NICON conference, where Valerie Watts is talking about TYC was in the context of 2011. We're facing a different context now with different challenges. Now, my view would be the different challenges and the different context has arrived because of the failure to implement TYC, funded, implemented or measured. So I think we should seek some assurance, reassurance, guidance, understanding of what it is from the department around that type of issue, and I'll get some more detail. And the secondary issue, I know now that we've lost the leader of TYC, and I think we should seek some information around what's proposed in relation to that, how they need to proceed. My worry is that somewhere or other the department and the board have decided to move on from this, and at least within TYC you had the measurement and the targets and all the rest of it. If they move off this without any consultation and without anything, the work still needs to be done and all the rest, but there will be nothing left to frame around your discussions or challenge.
Okay, I mean, members happy to do that, happy to seek that update, particularly in terms of the assurances required when there are gaps in terms of the delivery or strategic delivery now, and how those gaps will be identified. Happy to seek those assurances.
I have no problem with that at all. My concern is that the system, the more evidence we're getting, the system appears to be much more fragile than we all anticipated. I think we've heard from our RCN and from the nurses and midwives, we've heard from GPs, we've heard from we've had a number of evidence sessions. I would like the committee to take some time to review all that we've heard, to come to some sort of conclusions, and that's about then getting the department on the spot, and Valerie Watt and the board and all the rest of it. We need to put these folks to see what they're going to do about it or what the plans are. But if you've got unsafe nursing staffing levels in wards, that has to be addressed urgently, for example. We heard from Tom Black last week and the GPs, similar sort of situations. So I think there are major concerns, and I think we would be derelict in our duty if we weren't doing that.
Well, I mean, we would be, and we have to address those issues, and we do have to be taking, we have to reflect on, for example, there's a whole section of people that we haven't heard from yet in the allied health professionals.
Yep.
So we need to hear all of the evidence and pull it together. In my view, there is a real issue in relation to the design of the system, being able to cope or deliver or respond to the needs of the policy direction. Increasingly, I think the design of the system within health is not fit to do that. And I think there's a real hard conversation in and around that. But rest assured, from the committee's point of view, it will be about very clear action and recommendations and going forward. Kieran, had you indicated?
Yeah, well,
that?
just given what we've heard this week and last week, I forget what the term, what do you call them, mentioned there, but certainly dead in the water, transforming your care, and we're still, dribbling on. I think we should be asking those responsible at the top for to come and answer questions on where we're going, what they see is.
Well, I think what we've heard today as well is that it was a vision without action. We've then heard the right to question, is it now a viable strategy? And I think part of that is what we will be seeking in terms of assurances from the department and from the minister.
And the danger, as far as I could see, is that if we go from that situation, we're going to end up with action, which is cutting action without a vision. And that's not going to be good.
I think there are cracks appearing all over here. The cracks need to be repaired before we even start thinking about new strategies and all the rest of it. I think just what we're hearing here is, I would say, deeply concerning. We're in dangerous levels here, or getting towards those sort of levels from what we heard last week and this week, and from others. So yes, and maybe we'll get rays of sunshine coming through. Yeah. But clearly, there are major problems here.
Major review, reform needed. Okay, members.
But
Points well made, Kieran.
No, are we going to bring somebody in?
We are writing to the minister on the back of seeking assurances, first of all, in terms of the policy direction, and also about the gaps in terms of delivery of that strategic vision. We will be reflecting on this today as well, and yes, as a committee, we will be coming forward with very clear recommendations in relation to workforce planning going forward. Okay.
Fine.
Okay, members, item 6 is the forward work programme. I'm just asking people to note.
Great.
Item 7 is matters arising. There are 3 items under matters arising in the meeting folder. Are members content to note those?
Great.
And item 8 is correspondence. 10 items of correspondence. Again, in the interest of time, just want to draw your attention to several of them. Page 56 is correspondence from the department outlining the outcome of the public consultation exercise on the new adult safeguarding policy. An electronic copy of the consultation summary report is available from the committee office on request, advising members that departmental officials are currently reflecting on the responses and that a copy of the final policy will be sent to the committee prior to its publication and launch on the 17th of June. In terms of the proposal for adult safeguarding legislation made by the Commissioner for Older People, the response is saying there was not a consensus of views that the Department intends monitoring how adult safeguarding legislation is operating in other jurisdictions before taking the matter further. I'm suggesting, members, that we write back to the Department and ask them what the key issues were. I mean, we heard very robust evidence from the expert who attended along with the Commissioner for Older People in terms of other areas and other countries and what the legislation looked like. So I'm asking that we write back to the department to ask what the key issues are in terms of the possibility of legislation and what stakeholders expressed a view on the matter.
Yeah, right.
Page 68 is correspondence from allied health professionals seeking to brief the committee on workforce planning in the context of transforming your care. We have invited the allied health professionals to the committee, and committee staff will follow up on this matter. I think it's part of the overall discussion that we're having today. 69 and 77 is correspondence from Cancer Research and ME Support, asking that the committee supports their applications to have Parliament buildings lit up in colour in support of World Cancer Day and ME awareness. Just advising members that the Assembly policy on lighting the building exterior states that only events organised at Parliament buildings or within the Stormont estate will have access to the lighting system. The groups making the request are not holding an event in Parliament buildings or within the estate, but I'm seeking agreement that we advise the groups of that policy and suggest that they contact the events office to see if, if they have any other queries or if there's a way through the policy.
That would mean it wouldn't happen this year, effectively.
Well, I suppose it would depend on if both organisations now can host
Could quickly get in
an event.
Okay.
I think that would be.
Would we be willing to back that event?
Well, I would have no issue with backing both the organisations. Okay, but when the clerk just advised me we would need formal letters on from both organisations as well if they wanted to do that.
Okay.
But we can do that, that's not an issue. Page 10 of the tabled booklet is correspondence from ME Support regarding concerns that they had about the proposed condition management programme. I'm seeking agreement to invite the organisation to discuss the issue, invite them on the stakeholder event on the 20th of May.
Right.
Suggesting agreement to note to remain in correspondence unless members have any comments they wish to make, any other business. And date, time and place of next meeting is the 29th of April, starting at 2 p.m. in room 29. Thank you.